So the next section, we will sort of continue what to do with the screening. Okay, so we talked about the medical basis of the illness, talked about heritability, we talked about prevalence, we talked about severity. We're going to talk about, we talked about screening. Now, we get them from screening into further evaluation, because just like any medical illness, after you screen positive, you got to do the dive, right? The deep dive. You got to evaluate this thing, and then where do you put them for treatment? So we're going to look at the DSM criteria, which helps give us the severity, the American Society of Addiction Medicine, ASAM criteria, and the dimensional assessment is going to tell us what level of care they need to be at, and then we're going to understand the spectrum of illness. So, according to DSM-5, we've changed some terminology. All addictive disorders are now part of a continuum called substance use disorders. We used to, I'm sure several of you remember abuse versus dependence. There was a lot of confusion with that, because there's physical dependence, which is not addiction. It's just dependent. Whether it's a beta blocker or whether it's a routine, a medication that has caused a physiologic response that when I stop it, there's a rebound. So we're avoiding that, and we're talking about the substance in mild, moderate, and severe. So the 11 diagnostic criteria are as follows, but I want to give you a mnemonic. Remember that from med school? Don't you guys remember mnemonics? This is fun. It's twist caps. Just write down twist caps. And you don't have to open the heavy DSM manual so much, and you don't have to open the ASAM criteria large Bible. You just sort of say twist caps. Tolerance, withdrawal. I, for the intended. I used more than I intended to use. S and the T, time spent. Use 2 letters there. Time spent. I spent too much time obtaining the substance, using the substance, or recovering from the substance. The C, I tried to cut down or control my use. The A is actually a skip letter to P. Persistent use. The P is persistent use despite adverse consequences. What are the adverse consequences? Well, could be a lot of things. I mean, my health. I went in the hospital. Doc said if I drink again, it's going to kill me. But then I went back out and did anyway. Whatever the consequence is, typically a severe health consequence, but it can also be a relationship consequence, a work consequence. But it's that pattern. Persistent use despite adverse. I created that reality in my mind where it was okay. It was okay to me, but if you take a survey of anybody around me, they'll say it's not okay. It doesn't make any sense. And then the S is the social, occupational, relationship, activities reduced or given up. I'm just not going to go do that anymore. I used to have a hobby, and I take no interest in the hobby anymore. I think I'm going to go seek other, substances. I'm not going to spend time in the social world. My work is going to suffer potentially, and my relationships are going to suffer. So the twist caps get you a long way, at least in getting a good idea how many criteria. It's not exactly all 11. One of the things they did is they put in craving. I thought that was good. They eliminated legal, which is questionable, but they put in craving. You ask the person, do you crave the substance? But most people who have this illness, they have trouble articulating what is a craving. It means something different to each people. The folks who episodically use will say they never crave. They never crave. But that doesn't make any sense because every 2 weeks, the wheels fall off. So something happens before, and it's just, I got bored, I got tired, or whatever. So there's a little bit of an insight problem, but it it did meet diagnostic criteria to be included in DSM-5 as a reliable criteria marker. Craving. So you just ask them, do you crave? And I say that one because it's not exactly on my Kit Kats. And tolerance and withdrawal are just a physiologic piece. There's just less emphasis on that, but it's worth asking. So, of the 11 criteria, if you have 2 or 3, you've got mild disease. And if you got 4 or 5, you got moderate. If you got 6 or more, you have severe addictive illness. It's called substance use disorder, but I'd like you to be able to interchangeably say addiction, substance use disorder. So 2 to 3, I mean, part of it, it's the pattern thing. It's not the one-off, okay? So I do want to put that little caveat in there. This is not the person who had sort of everything together and they've had like a pretty severe consequence. Let's say they're not a typical user of substances or drinker, but there was this like one incident where they drank too much and got a DUI, but it was like a one-time thing. That doesn't necessarily meet the criteria for addiction or substance use disorder. It's more the pattern. So the more informative question after that happens for somebody is like, well, what did you do after? Oh, well, I just continued to drink, but I never got caught anymore. Specific substance categories. There they are. Again, we have to have it for nomenclature. We have to have it so that we may be able to deploy the tools at our disposal to help these folks in the craving phase, the withdrawal phase. Again, Band-Aid on the wound. So we really don't care about this, but we did. We don't care, but we do, because we need to know, Doc, why all this emphasis on what I'm using, how I'm using it? Why does it matter if I put a needle in? Well, it's a marker on, it wasn't in the DSM criteria, but it should be. If I'm using intravenously, it does lead itself towards the severity being worse. It's no accident that I move from oral ingestion to snorting a medication to injecting a medication. Why is that not an accident? It actually cuts the time off from that substance getting from the point of entry to the nucleus accumbens to release dopamine. What's the fastest route of administration of a substance to the brain to release dopamine? It happens to be the inhaled route because you bypass the whole right heart. If you inhale something, smoke it. It goes right to the lungs, to the left heart, to the brain. Even if you IV it, you have to kind of go through the right heart, don't you? So that's milliseconds or tenths of a second or seconds or whatever it is. So there is no accident that I start using something orally, chew it up, go through the digestive, the intestines and absorb, and then I start maybe insufflating or snorting it, and then I inject it and or smoke it. Some substances are not readily absorbed through the alveoli or through the lung fields. And that's why not everything ends in the fastest route, but some obviously can be injected, dissolved and injected. So anyway, it's a marker. It's not on the DSM, but I want to bring it to your attention because it is an important piece to the puzzle. But then in the end, it doesn't matter, right? Because I have addiction. I'm trying to help this person. They're full of shame and guilt because they're using street heroin instead of oxycodone prescribed from my doctor. And it really doesn't matter. Okay, so you need to look at these folks on the deeper dive. They screen positive and they're coming in and for an assessment. And if you were on the front line wanting to take care of them, you've got to look at 6 areas, 6 dimensions. And these are the American Society of Addiction Medicine multi-dimensional assessment of addictive disease. Dimension 1 is withdrawal potential, which has to do with risk and detox. What are the 2 sort of withdrawals that that can kill you? Alcohol and benzos, right? Opioid withdrawal may feel like I don't want to go on, but it's not labeled the same level of severity. But you got to pay attention to it and treat it. How about cannabis? Does cannabis have withdrawal? Sure does. Sick with vomiting syndrome, not eating, anxiety, insomnia. It can be pretty rough. You name the substance, even though it's not always classified, there's some amount. Because if I'm taking a substance, right, when it's working, it's doing certain physiologic effect. There's always a washout. So if I'm taking a stimulant and it's got me up for 2 or 3 days, or I'm feeling very hypomanic, or I'm feeling euphoric, you can imagine in withdrawal you're having depression. So severe depression and suicide risk is high after amphetamine, stimulant, or cocaine use. The next few days are horrible, high risk. Call it a withdrawal or not, but it's a wash in and a wash out in a clinical risk setting. So you pick the substance, and there's going to be a Dimension 1 issue if they've used it in the last week. Dimension 2, biologic or medical conditions. Doesn't matter that the person has addiction in the setting of CHF. I would say so. How about chronic kidney disease? How about severe hypertension? And then they're going to go through a withdrawal that's going to spike their blood pressure. So Dimension 2 is very important. And Dimension 3 is basically the psychiatric dual diagnosis component. If they have a co-occurring mood disorder, co-occurring anxiety, trauma-like illness, that's also important to assess. Dimension 4, readiness to change. There's a model of Prochaska Clemente stages of change where people move from pre-contemplation, contemplation, preparation, action, and maintenance phases of change. And where are they on the continuum? How motivated by the pain and loss are they? If things were going well, they might not need the help, and they might not receive it. But the question is, you've got to give them sort of a rating in their readiness to change. Is it all external, like most folks, which put it pretty high as a risk? Or do they have some emerging internal motivation which takes that risk down a little bit if they start to see a little more fear of the disease than fear of change? Remember the fulcrum we talked about. Where is the bottom? Fear of the disease is greater than fear of change. Do they have some of that emerging? Relapse continued use potential. That's important in Dimension 5 because, some people say, look, I'm not going to change my living arrangement. I live with the person I use with and want to try to get well in my current environment. I'll just watch them use and I won't use. I'd say that's pretty risky, wouldn't you? So it kind of leads into Dimension 6, where they live. Dimension 5 really speaks to coping skills also. The relapse potential. What have they learned? What have they been able to pull off? So, in Dimension 5, we're looking at coping skills to maintain abstinence, coping skills to deal with life and stress without putting a substance in their body. Dimension 6 is the living environment that I'm sort of alluding to with where do you live and who's there? Sometimes being alone is the worst thing in a way. They get sicker by themselves. But if they're, I would say the high-risk ones are living alone or living with somebody they're using. Risk rating in each dimension guides treatment placement. So you got to go low, medium, or high. You got to give a risk in each of those 6 dimensions. And where that shakes out is where they should go. Now, here are the levels of care that you could choose from after you give them a risk rating. To make it fairly straightforward, if they're lower risk in the 6 dimensions, then they could do outpatient. If they're higher risk in any of these dimensions, you have to think of these higher levels of care. So basically, levels 1 and 2, there's a kind of a hybrid that happens at 2.5. So it's like level 1, which is outpatient, and level 2.1, which is intensive outpatient. Those are outpatient, reside at home. Now, when you get into the partial hospitalization or day treatment, you have an option to have a supportive housing component or not. If you have a supportive housing component, that's obviously can handle a riskier person. If they're going to reside at home and commute to your program or whatever program it's in, they have to have a support person. They have to have someone who's willing to maybe transport them initially. They stay accountable with the medications. It's one of the things we're going to talk about later. When you prescribe a medication for someone, if you wanted to help, you just have to be careful on, I know they live alone. I know they have trouble with medication. Just write in the script to kind of be alone with it, as opposed to, can I bring somebody into the equation? Family member, loved one, sober support to help them handle their medications in the short run. Level 3 is residential, where it's basically 24/7. You have that supportive milieu where they have a social structure and they're around other folks getting well. And then level 4 is actually in the hospital for the most part. There's not a lot of therapy. It's more medically intense. They're just so sick at that point that therapy is not the focus like it is in level 3 and 3.5. Oh, and number of hours per week too. That's an important thing. Each level of care kind of dictates the hours. When you're talking about intensive outpatient, that's anywhere from like 9 to 15 hours. When you're talking about the partial hospitalization, it's 20 to 25. And then you're living in those places, so that the hours, of therapy, and it's combinations, individual therapy, group therapy, but the modalities are similar. CBT, cognitive behavioral therapy, still is the gold standard for treatment of substance use disorders. We use motivational enhancement, DBT for people who have, emotional co-occurring disorders. Dimension 1, first things first, medical risk. You don't want someone having a seizure or a fatality because they're in withdrawal. So that's why ASAM has put Dimension 1 as withdrawal potential and withdrawal risk, because it's most important. Medically driven. And medicines that we use here, you guys have seen this, happens in the hospital, can happen outpatient. But it's definitely a first step in getting help for the disease. And the main reason that a qualified healthcare professional, whether it's a physician, nurse practitioner, or a PA, have to be part of the team. Scheduled medications, long-acting though, like Librium, anticonvulsants, antihypertensive, and buprenorphine are often used during this time to decrease the chances of medical and behavioral complications. Medical risk here, so you need close monitoring. Can be done under close supervision outpatient. You have to have a team who's familiar with it and a provider who's experienced in it and knowing where the limits are. You may be able to outpatient detox somebody who's doing a 6-pack a day and they're having some mild withdrawal. But you got somebody who's doing 12 to 18 beers plus 6 to 8 milligrams of Xanax and a seizure history. Yeah, they're going to need to check in. Treatment works to normalize dopamine levels in the survival pathway. There it is again. We're going after something, right? We're going after a target. The target is dopamine levels in the nucleus accumbens. We are working to normalize dopamine levels in the nucleus accumbens. We're going to use every bit of what we know. All hands on deck. We've got medications, therapy, exercise, diet, connection. The opposite of isolation. Isolation and connection. We need healthy relationships. We need to remove stress and unhealthy influences. And we need to have some level of understanding and acceptance of the disease. Reducing stress, right? I mean, it might not just be putting in a positive where, I'm going to spend time with that positive person or that person who really supports me as a person, supports my health. That's good. We want to put in the positive. But it might be, I got to get rid of that toxic one. That toxic one keeps insulting me. That toxic one puts a lot, I got to separate. How can I get well when I'm constantly bombarded by the negative influence? So I might need to remove the negative, put in the positive. So, they say recovery is easy, just change everything. Length of treatment varies with severity of the illness. But NIDA is pretty clear on that. NIDA is pretty clear into 3 months. A lot of these one and done. Hey, it's a 28-day program. It's a 30-day program, one and done. They're nowhere. I want you to think of that as stabilization. 30-day program is stabilization. for most people with severe disease. Again, is it going to work for mild to moderate disease? Maybe so. Maybe somebody with mild to moderate disease goes for 30 days. They get a real boot camp, and they just go home and change so many things, go to meetings, get a sponsor, work steps, take the right medications, and they're good. That's really in the past. So there's many paths, but I'm bringing to you the fact that if you're looking at large numbers and you're looking at people with more severe illness, you're going to really need a longer duration of treatment. Now, it can be combinations of things. Maybe they go in for 30 days, but they got to tie, maybe an intensive outpatient program on the back end of that to sort of finish it out and reintegrate into the community. If I go in to a residential place, right, I'm surrounded by the milieu of recovery. But what happens when I come home or I come out? Where is that support? Where is that structure? It's, from the fishbowl to fish out of water. I need a transition for most people. If they have severe disease, they're going to need a longer treatment course than 30 days. And NIDA seems to support that with their 13 principles of effective addiction treatment they have listed in their guide, the research-based guide, 3rd edition. But patients with this disease need lifetime maintenance and awareness. Like any other chronic medical illness, we hope for remission. We're going for full remission. But they need to be aware that there's risk. How to best encourage needed treatment for substance use disorders. Help the individual see the power of the illness and its unintentional effects on those around them. There it is again. The unintentional, they never meant for it to affect anybody else. They really didn't. But it did. And if in a gentle, compassionate way, you can point out how it did, you're going to have more traction. It's not to throw anything in their face. It's not for shame and guilt because they're feeling bad enough about themselves. It's for the very simple point that this disease is stronger than they thought it was. We need to move the patient from feelings of shame and guilt to where? To shock and awe at how powerful the illness is and that it did things I never meant it to do or it wasn't supposed to go there. So you're moving them from shame and guilt to shock and awe, but supporting the good person that they are underneath. So some of that stuff is used, the communication strategies like a motivational interviewing, motivational enhancement therapy. These are the techniques, and talking as we are talking now is very effective in moving patients in a direction to help them see that it's not them, it's their illness. And you can almost separate them out into two different things. One is the person and the two different people, if you will. So you're really looking at the right level of care based on the dimensional assessments. You really want to have the support people there when you're talking to them, if possible. It's not always possible. I mean, at the bedside, they're not there 24/7, and you might have to work with trying to move them along the stages of change with their internal motivation based on really fear of the disease. I'm in the hospital bed. I never meant it to get here. So even though it's more powerful to think about how the disease has impacted my loved ones, it's actually, there's a chance that if I'm sitting in a hospital bed and I'm thinking about how bad it's gotten for me and it's sort of a near-death scare, that could precipitate some movement towards getting help for oneself. So you want to make use of that. But if you can have support system, support people there, it's much better. We'll talk a little bit about, if possible, and you're going to use medications to treat this illness outpatient, try to involve another support person so that they can hold and administer the medications. Initially, think of it like a broken bone, right? Even if you've been training for the marathon for 5 years, it doesn't matter if you broke your ankle, you're not running in it. So if they're in a fragile state because they're sick from addiction and they're having trouble managing powders, liquids, pills, everything, you want to get help involved. So you want to have somebody hold and administer medication initially. After 30 days or something like that, they can probably fly on their own. But if you can, get somebody to help them hold and administer medications initially, you'll be going a long way and really supporting them on an outpatient basis to get better. But usually after 30 days, they can kind of manage their own meds. understanding the disease. Help the individual move from shame and guilt to shock and awe at the power of the illness. Help the individual and family understand that using chemicals is only a symptom of their underlying need to increase one's own dopamine levels or to address another core issue. Back to the Band-Aid. We're looking at what is it? Opioids, cocaine, stimulants, alcohol. What is it that's on the top that we're using to cover something? Help integrate the understanding of the neurobiology with understanding their behavior. We talked about having a high glucose and being different. We talked about being 5 days with no water and making decisions that wouldn't make sense to other people. Explain how stress, environmental cues, and exposure to substances influence the illness. So these are things to help explain to the patient directly and also to the family who's supporting them, and so that we can cut down that shame and guilt. Why is it important to cut down the shame and guilt, you think? When I feel bad about me, it's easier to hurt me. When I feel good about me, it's easier to keep doing good things and support me. So we have to get them thinking in a direction that is supportive of them as a person, because it's good for their health. The beating myself up philosophy and hard on myself and, keep that going, that's not helpful here. In fact, it makes things worse. So we're trying to celebrate the small wins. So you didn't use today. That's great. I'm glad you didn't use today. When is the last time you've gone a week like this? Well, it's been years ago. Well, that's great. Keep it going. You really need to keep this going. And so encourage the abstinence and the use of the medication. But they do need accountability. The other thing they will ask for is, I'm glad you test me, doc. I'm glad you do the urine drug test. I'm glad you do whatever you do to monitor me, because if I wasn't going to be tested, my brain is still healing and it pulls me sideways. And I might be thinking about using, but I have to come and face you. I have to come and do this test. And I don't want consequences from that. And so I keep going forward. It's just like, the accountability when you're treating a medical condition. You're wanting to make sure they're on the right path, whether it's a diet log, a glucose log, or other sort of parameters for other things. You're giving them guardrails, and it's helpful. It's not punitive. It's part of their recovery plan. So here we are with the training, and is why, we need to kind of focus on what we can do about it, because the mortality is so high. And we're learning about screening for it, we're learning about assessing, but what about the medications we can use to prevent death? That's what we really need to how do we bring that home? Those numbers are staggering. Back to the X waiver, because in terms of tools that we have, it seems to me the spirit of the law that was passed in this training is that providers will have the education about the disease of addiction, but there will also be some providers and an increased use of this buprenorphine medication. You're going to see it more. Whether you write it or don't write it, you're going to see it more. And it gets back to the prevalence. The same way back in the day you saw metformin more, came out metformin, and metformin was good for diabetes. And we know from the slides that, the prevalence at 11% versus 16% for addiction. And, those overdose slides say 80% of the deaths are very much tied to opioids. And buprenorphine is the medicine we use to help decrease the likelihood of death. FDA-approved medication for substance use disorders. It's come out. You may have heard MAT, medication-assisted treatment. Medications can be initiated and used at any ASAM level of care. As you remember from before, we were talking about the multiple levels of care. You can have outpatient, you can have intensive outpatient, partial hospitalization with or without housing. You can have residential, and you can have it in the hospital. So this is sort of say an independent thing, but it's an add-on, and you can have medications in any setting in which the person is receiving treatment for their addictive illness. But you got to remember to check withdrawal potential. Dimension 1 on ASAM. Evaluate for medically assisted withdrawal management, also known as detox need, and the appropriate level of care first. That's that ASAM Dimension 1 risk level. Got to rate it. Again, you start hearing things like previous seizures, previous delirium tremens, which, by the way, is a very specific finding. Several of you here know carries a high mortality. It's not just hallucinations. It's not alcohol hallucinations. It's not hypertensive crisis. It's the combination of mental status change with that hemodynamic instability. So that's the part that's really the red flag. It's kind of the double dose, double finding, and you really have something there that's high risk. So we'll review medications used for the following substance use disorders: opioid use disorder, alcohol use disorder, tobacco use disorder, which I think should be named nicotine use disorder, stimulants, cocaine, cannabis, and sedative hypnotics. So, assessment. Does this patient's diagnosis and risk level fit my practice capabilities? So here we are potentially with the implementation. As we're learning things here, starting to put together, can I do this? Can I do this? Or do I need to refer them to a higher level of care, like the emergency department or inpatient, residential detox, residential treatment, PHC, IOP? If the patient fits in practice, then go for it. Institute needed medications, protocol support system, and monitor closely. We'll talk about what that looks like. And I think that is the spirit of the legislation, the spirit of the training, is that folks are going to use buprenorphine. Some folks will, particularly primary care, as we were talking about. Yeah. The ideal patient for outpatient management of substance use disorders is the patient is low to moderate risk in those 6 ASAM dimensions. They have family or sober support. They're open and willing to present to the office for weekly checks or more frequently if indicated, possibly 2-3 times a week in certain cases. Patients on lower doses of alcohol, opioids, or other substances. Patients using opioids orally or intranasally. There we are back to that route of administration again. Does that mean something? Well, route of administration does mean something. And it can be a window just for insight into how bad things have gotten, and when things are desperate, how far am I willing to go? Like, I haven't crossed that line yet. Oh, then I cross it. I haven't done this yet, and then I do it. And for a lot of folks suffering with this illness, it's like that. The power of the illness literally drags them by the neck across many lines of things that they wouldn't normally do. But that's more of a marker on the severity of the illness, and it's just that strong. So if they're using IV or smoking opioids, you still could treat them outpatient possibly. However, additional caution regarding increased chances of breakthrough craving and need to refer, having someone to consult with, because doses might be a little higher, the checks are a little more frequent, and having a support person riding along with you would be important if they're using intravenous. Route of administration is an insight, as we mentioned, and might point to need for more support. Workup during evaluation for using medication for addiction treatment. History and physical, we haven't moved from that. History and physical. Vitals and in-office testing. Boy, this is where, urine drug screening becomes very important, because there is, even though I'm coming in for opioid use, I just didn't want to mention that I do cocaine too. And so I have to be able to get a sense of what I'm using, and does one carry risk separate from the other. So I need that urine drug test. And that's one very practical step. If you're going to treat patients in the office and you're going to prescribe buprenorphine, you really need to get the qualitative urine drug testing cups, and you can put those in the office and use them. I recommend a 12-channel cup, so you can see the majority of things. Again, you don't get everything. There's stuff out there we can't see. Talking on break about Zalazine, and the next part of the conference on the 24th, we'll be talking about, some hidden risks and dangers, emerging threats. We'll be talking about rescue medications and stuff like that with naloxone. But you're not going to catch everything, but you got to do something. So you want to conduct your C1 and CAL score. That's going to be a new acronym for many, but it has to do with alcohol and opioid withdrawal. We're going to check the PDNP. We're going to add potentially. So this test I was mentioning for alcohol, why is that important? Why do I need to know? Isn't alcohol just fine? Why does alcohol count? Well, turns out it does release supraphysiologic amounts of dopamine in the nucleus accumbens. So although it's not a DEA scheduled substance, it still has an element of risk, even for people whose drug of choice is cocaine or people whose drug of choice is opioids or sedative hypnotics or stimulants, you name it. Alcohol, you need to know. And you can imagine that sometimes patients, if you're going to prescribe a medication, such as buprenorphine, and you drink on top of it, you will be introducing the risk for heavy sedation. Even though buprenorphine is a safe medication in and of itself, when you combine it with alcohol or you combine it with sedative hypnotics like Valium, you're introducing the risk for respiratory depression and potentially death. So you got to be careful on how much you're drinking. So ethylglucuronide, it comes in a test strip, or you can add it onto your urine cup. And again, it's alcohol use and all that. And it's not, you like to say don't drink, but it really does go to a dose response. I mean, it depends how much they're drinking and how much risk that introduces. Now, kratom is a new thing, or old thing, but I mean, that's sort of right down the street, sold as a herbal or a supplement, but it's, basically an opioid and a stimulant mixed. Mitragynine is the sort of generic name. It's a plant extract, but it has opioid and some stimulant-like properties. So people who are using it, potentially putting it in capsules, brewing it up as teas, something like that. But there are some dipsticks you can get for both ECG and kratom to add onto your cup. Fentanyl and xylazine, still kind of tough to test for those in the office. You got to send out your sample. So usually you're coming in, doing a workup, history and physical, you talk with the patient. You're doing a standard cup in the office that you can read, but then you'll have to send it out to look for these other things. It's a little more detail on the CEWA score. I bet most of you in here have heard that's been around a long time. We use that to measure the intensity of alcohol withdrawal. And there's even one for benzodiazepines. It's pretty similar, just adapted for benzos. But I've always said benzos were alcohol in a pill. You guys heard that before? Alcohol in a pill. Because it's that GABA A receptor, right? GABA A. They both hit GABA A. Problem, of course, because some of that is fast on, fast off. When you have something like alcohol, it's on the GABA receptor short time and comes off, you got withdrawal. When you have alprazolam or Xanax and it's fast on, fast off, you got withdrawal. In the wrong person, you don't have the physical dependency, you get addiction. But in people who don't have addiction, you may be able to just use it, but then just deal with the physical issues and potential physical dependence or just physical somatic symptoms. So in this case, we're looking at a score. And in the parameters mentioned here, agitation, anxiety, auditory disturbance, sensorium, headache, nausea, vomiting, sweating, tactile, tremor, and visual. Less than 8, tell you the truth, if you know the history is there, no matter the score, if somebody has been drinking, this one in particular is for alcohol. We'll do it for opioids and we'll do it for benzos. But picture this, right? I have the disease of addiction. I've been using for 5 years and I'm coming for help. And the help that I get is just stop using and you'll be fine. Like they've heard that before. Like that's an easy one. I've heard that 100 times and it's useless advice. The point is, their body, their mind, their central nervous system has gotten used to seeing the GABA A receptor occupied or in withdrawal, either intoxication or withdrawal state. So just having them abstain after years, 5, 10, 20 years of using a substance is not going to be easy, and I don't think it's realistic. So if you're going to treat somebody who's coming for a problem because they have difficulty with regard to their alcohol use, if they have any level, if they drank in the last, week or two. No more of this, well, you're over withdrawal. It's not about withdrawal. It's about craving. Remember that other DSM criteria is craving. What are they going to do when stress hits? They got no coping skills yet. They haven't learned anything yet. They don't know what's going on yet. So even though they haven't drank in 10 days, the wheels fall off when they do drink. And what happens when they get caught off in traffic on the way home? What happens when their spouse yells at them? What happens when their kid spills something? What happens when they lose their job? They can't handle stress yet. Their coping skill for stress is to drink. So you're going to have to be able to help them pharmacologically in the first month or so that they're learning how to be abstinent. So, but this is more specific for how severe is the withdrawal. And this gives you an insight into how much you need to replace. How much are they drinking? How recent? How high is the CEWA score? And there's protocols. There's a symptom-driven protocol, and then there's some standard protocols based on experience where it's like, look, this many beers or this many milligrams of Ativan or lorazepam or like alprazolam translates into this quantity of withdrawal medication I need to give. You're not going to find a lot of that in publication. It's more sort of in practice, and have done. After you do it enough times, you really have a sense of what the replacement needs to be. But CEWA scores, between 8 and 15, would be considered moderate withdrawal, and anything above 15 would be kind of more severe alcohol withdrawal, and they would probably need to be monitored in a setting where they have nursing. And you can do some other things, whether it's IV lorazepam or whether it's very closely monitored administration of Librium or Valium. So here's the scale. First nausea and vomiting, no symptoms, of course, is 0, and 7 is just constant with just retching in front of you. Tremor is from none to very severe. And just like we've learned medically, when you start to have the shakes and you start to see them all over the body and you say, stick your tongue out, let's see, and the tongue is shaking, it's a prelude to what? The person's pretty close to having a seizure, maybe. The next thing autonomically, what's going to happen? We're starting to shake here, we're starting to shake there. So the inhibition capacity, part of the GABA neurotransmitter system is starting to become unglued. And we're starting to see, we're starting to see instability, sweating, anxiety, agitation, tactile. You can see the count there, auditory disturbance, visual, headache. They don't have on here vital signs, but when you're dealing with either alcohol or benzodiazepine, withdrawal, which is what the CEWA score is for, then you have to pay attention to their hemodynamic state, and you have to watch the vital signs. You had hypertensive crisis on top of a CEWA score of only 8, you're still in a dangerous zone. You got to get them to the right place. This one is for opioids. So the CEWA was for alcohol, and this one is for opioids. The clinical opiate withdrawal scale, published in the Journal of Psychoactive Drugs in 2003. We rate the opioid withdrawal based on this scale. Now, of course, it's not always that clean because they might be withdrawing for both substances. So you might need to score them both, depending on what you get. But rest assured, when you get an opioid withdrawal scale above 13, you're in a zone where you can start the buprenorphine medication. But that's one of the caveats is you need to be in opioid withdrawal to use life-saving medication like buprenorphine to get people to stop using illicit opioids. So let's look at this. This does take into account vital signs. Look at that, pulse rate, at least. So if they're tachycardic, they're going to get a high score on this one. Sweating, restless, pupil side. You see there's a couple overlapping symptoms, from the CEWA score to the CAT score. But notice there, with opioids, there's this pain component, right? So they got pain, achy joint, bone pain. It's part of withdrawal. It's not because they injured themselves. It's because the opioid is washing out. They've been used to it, and now the withdrawal is causing pain, which over time, would resolve. Several people are on, they might have a chronic pain condition. So that's part of, one of the second parts of the talk has to do with pain management in people with substance use disorder, because those can co-occur also. So it's not just mental health and addiction that co-occur, it's chronic pain and addiction that co-occur. And you're allowed to have all three, mental health, addiction, and pain issues. So, you have to just look at all three. They have the rhinorrhea, they have sort of, it seems like things are flowing. If opioids constipate you when they come out, it goes the other way. So you might have diarrhea, you might have runny nose. The GI upset is up there, stomach cramps, vomiting, diarrhea, multiple episodes. Tremors here too, just like it was for alcohol. Yawning is a little different, unique. The yawn, maybe specific, like why? You're like in a crisis here. Why are you yawning? Are you tired? It's like, no, I'm withdrawing. Irritability, anxiety, and goose flesh. So these might be some cases where you might not want to take care of them right in your office. Patient with a history of seizures and experiencing severe withdrawal. Patient with current medical complications such as acute pancreatitis, GI bleeding, hemodynamic instability, and a CELA score above 15. Again, that's for the alcohol and benzo. And that's deadly if they have severe alcohol or benzo withdrawal and they don't get the appropriate treatment. They can die from that. So you don't want to take any chances with some of these. Patient using combination sedative, hypnotics, and alcohol at high doses. For example, greater than 6 to 8 milligrams of alprazolam a day, plus a fifth or 750 mLs of vodka a day, and live alone or maybe just with somebody who's using with them. High risk situation, tough to do much outpatient for them. But you want to try to get them where they need to go. Patient using high-dose opioids with heavy concurrent benzodiazepine and alcohol use with limited to no social support. High dose. So this is, back to the trifecta. You got high-dose opioids, high-dose benzos, high-dose alcohol. It's just that dimension one gets you every time. That ASAM dimension one, safety first. This is like a, medical withdrawal situation where, are they going to make it through the washout? Can you really handle that outpatient? Significant unstable co-occurring mental illness. They have schizophrenia. They have, they're in a manic state. They were recently vaporactive and also continue to be suicidal. This is going to be tough. If on top of that, they're using, intravenous heroin and they have unstable, untreated, co-occurring mental health. It's another situation where you're going to, on an outpatient basis, want to have them at the right level of care. All of these that we're going through, when you do your ASAM dimensional assessment, that's all 6 dimensions, you would see that they would test out very high risk in multiple dimensions, and that would guide you from the dimensional assessment, high risk. That would guide you to placement at the higher levels of care. It wouldn't be level 1 outpatient. It would guide you to level 3 residential of some type, whether it's detox or treatment. So that's how that scale works, the dimensional over to the levels of care. So we talked about that. Dimension 6 is actually patients living with others, using together, possibly living alone. You have part-time, it's taking care of that by yourself outpatient. So after you get through the workup, assuming that none of those things were there, basically they were lower to moderate risk in all 6 dimensions. The consent to treat for addictive disease is a little different than the HIPAA regulations. It's not exactly HIPAA. It's beyond HIPAA. It's this other federal confidentiality law called 42 CFR Part 2. It's mental health and addiction confidentiality. It has more layers to it above and beyond HIPAA. And you need a specific consent. And the second part of our series talks, which will be on the 24th, we will be sort of sharing these specific consents and forms that you would use to manage a patient with addictive disease, and also work them up and bring them, how to implement this with the documentation you would need to take care of them. And these forms will be shared at that meeting. You need a special pharmacy consent. You need specific releases for other providers, because this is part of that. Well, I didn't tell my primary, I didn't tell my cardiologist, but this is what's going on. They need to know also, so we're sort of getting consents for various disciplines. One thing we haven't talked too much about yet is the contingency plan. So I'm going to take them in and do my best to help them. However, I have an agreement with them or their family or significant other that if things don't work out, we're going to do the contingency plan. And you might be able to guess what's the contingency plan. It's going to be a higher level of care. If it's not working, it doesn't mean I do less. It means I need more. If I continue to use in the setting of outpatient, it's not like I just need to get a job, right? Back to that old thing. I know what it is, doc. I need to go get a job. The fact that I'm continuing to use in an outpatient setting means that I need more support, not less. So we need to go to a higher level of care. And that's what you have them sign up front. And you say, look, we can take a dive together because I'm trying to save your life here. But I need you to have this plan understood, assign this to say, like, look, if I come in and test positive, or if I am not doing well, then I'm willing to get more treatment, more help, not less. So specific medication consents, each one you use, it's like in mental health, addiction medicine, psychiatric practice, you don't have these procedures where it's like we got the blue tarp and we're going to do a sterile procedure and here's your consent form. The procedure that we have to offer is the medication. So you do a specific consent form with a lot of detail for each intervention you do with the medication. That's basically the procedure. So think of the medication consents as very essential for the practice of addiction medicine. Whether you're using psychotropic, mood stabilizer, antidepressant, or you're using buprenorphine, you have to have a specific consent for that medicine. After you finish assessing them, and they signed all of the basic documentation for releases and understanding the contingency plan, if I don't get better, I'm going to go in to a higher level of care, and you're deciding the patient's risk level fits my practice, then you move forward with instituting need medications for substance use disorder and the protocol. The biggest thing, I think, is this support system, trying to identify. And you can have it done whether it's on the phone before they come in, bring somebody with you. You just make your appointment. It's with somebody. I just don't see people with substance use disorder alone. That's just my policy. And that's kind of the way I do my practice is I just have them bring somebody with them. I don't really see them alone. You got to identify somebody who is who's well, who's a sober support, who is, sort of a clear mind and body. After all, this is a disease that affects thinking. My best thinking has gotten me here. And that's just because I was sick. So if we're trying to have a person with their thinking impaired because of the disease of addiction make the best decision for themselves, that's a tall order. It doesn't make a whole lot of sense to just say, well, what do you want to do? How about we get somebody who cares about you to come along with you and you make sort of a joint decision? Really, in a lot of ways, they're doing it for that other person, right? Like we talked about before. But there's nothing wrong with that in the beginning of treatment. I'm going to be willing to give this a try because I care about this person. Okay. And then eventually I'll start caring a whole lot about myself again. So the support system. Bring somebody with you if you can to get somebody. I can't say enough about that. It's very hard when somebody's very ill to try to treat them as one provider to one patient, just one-to-one. Very difficult. For all the reasons we described earlier, right? So, get some